Hello and welcome to another Applied Radiology Expert Forum webinar. Today's program is entitled, The Role of Productivity Tools in a Post-COVID Surge. Today we'll have a primary focus on tools for the use of MR and CT suites. The COVID-19 pandemic has led to a marked and likely transient reduction in scanning volumes, as attention has turned to caring for the critically ill. However, as we emerge from this crisis, we anticipate a surge in routine imaging demands. And coping with this demand will require leveraging tools that enhance efficiency, workflow, and safety. I'd like to take a moment to introduce Dr. Lawrence Tanenbaum, who is the Vice President and Chief Technology Officer, also the Medical Director for the Eastern Region, and the Director of MRI, CT, and Advanced Imaging at Radnet. Dr. Tanenbaum, do we have you on the line?
I believe so.
Well, I'm glad to hear it. Thank you for joining us, sir. My name is Kieran Anderson. I'm the group publisher here at Applied Radiology, and I will be your host and moderator today. Today's program has been sponsored by Philips, and we would like to thank them for their continued support of events such as this. Following Dr. Tanenbaum's presentation, we'll have time for a brief Q&A, and we encourage you to submit questions at any time during the event. As a reminder, any information presented here today is that of the speaker, and any findings, data provided are based on work at their institutions and may not be reflective of other installations and our Philips healthcare policy and compliance. Here, I'd like to run through a few quick tips for viewing the program. You should be seeing a screen that looks something like this. In the top right corner, you can click one of these buttons to increase the size of the slides. Over here to the right in our resource area, we have a number of links and documents, including a compressed sense case study from Radnet that Dr. Tanenbaum put together for you. Down here in the bottom corner, you can enter questions that you may have for Dr. Tanenbaum, and we'll address as many as possible during the Q&A section. Click Submit to send them to us. And here in the control panel, you can toggle these windows in and out of view to increase room on your screen. So before I turn it over to Dr. Tanenbaum, I'm going to launch a quick poll here. I'd like you to participate in this, and we have a few more during the course of the event. We'd love to get your feedback. So here we have, what are you expecting in your departments as we emerge from the COVID-19 pandemic? Are you expecting a slow and steady ramp up? Volatility and fluctuations in demand? A prominent surge with a reduction in COVID-related restrictions? Or do you not expect volume to return? Take a moment, please participate. I'll share the results, and then I'll turn it over to Dr. Tanenbaum, who may comment, and we'll get into his talk. Let's take a look at what we have here. So at the moment, Dr. Tanenbaum, you can see that about 50% are expecting a slow and steady ramp up, 26% a prominent surge with a reduction in COVID-related restrictions, and 21% volatility and fluctuations in demand. So with that, Dr. Tanenbaum, I'm going to turn it over to you, let you take control, and thank you again for joining us today, sir.
Well, you know, Kieran, I always like to throw you under the bus, so right now I'd like to thank you for taking the survey results off my screen so I can't comment on them whatsoever. So welcome, everybody. We're going to talk a little bit about the role of productivity tools in imaging after a post-COVID surge. To the best of my knowledge, about half of the respondents commented that it would be a slow, steady rise. And with a significant number, about a quarter of them thought that the case burden will be a bit fluctuating with periods of high activity and slowdowns, which is kind of where I think we're going to end up. But over the course of the next 45 minutes to an hour, we'll talk a lot about some of the productivity tools with CT and MR that may be helpful in the post-COVID surge. But I figured that with COVID in the title, with all of what's going on around us, if I didn't spend 10 or so minutes talking a little bit about the imaging of COVID itself, it would be wasteful of everyone's time. So we'll go ahead and start off with something like that. So we're clearly in challenging times right now. We're right in the heart of the COVID pandemic worldwide, perhaps past the first wave at least in the United States, and it's worthwhile spending some time talking about what is COVID-19. We'll talk a little bit about the imaging findings. We'll talk about some of the society recommendations. I'll mention some of the work that folks have done with standardized reporting and things like CORADs. We'll talk about the disease itself as well as some complications. We'll also talk a little bit about the role of artificial intelligence machine learning tools in both the evaluation and surveillance of patients with COVID. And then we'll transition for the second 60% of the presentation into some of the tools that we may or may not have, that we might acquire or utilize that will help us in dealing with some of the challenges and opportunities about the pandemic. I hit the wrong button. So what do we know about COVID-19? Well, this is a severe acute respiratory syndrome caused by coronavirus 2, otherwise known as SARS-CoV-2. SARS-CoV-2 is colloquially known as the coronavirus. The coronavirus is a positive sense, single-stranded RNA virus. It is a strain of severe acute respiratory syndrome-related coronavirus, and it's believed to have zoonotic origins and likely emerged from a bat-borne virus with a spillover event to humans, likely occurring in late 2019. COVID-19 is primarily spread through close contact with an infected person via respiratory droplets produced from coughs or sneezes, and now we know even talking. This slide is only about a week old, but at this point there have been over 1 million cases in the United States, which is certainly the largest amount of cases in any nation worldwide. If you are interested in the clinical symptoms, the CDC updated the list of clinical symptoms that should be indicative or suggestive that you are dealing with COVID-19. We knew about fever and cough and shortness of breath, but also patients have presented with chills and shaking, but some other things that may be somewhat atypical, which are muscle pain, severe persistent headache, sore throat, and really the secret hallmark to all of this is loss of taste and smell, which correlates really well with the distribution of COVID and is now considered to be a classic clinical symptom. As you may know, COVID mainly enters human cells by binding to the receptor angiotensin-converting enzyme 2. This particular receptor is on endothelial cells throughout the body, and it has been associated with inflammation of those endothelial cells throughout the whole body and may be the common theme behind all of the symptoms that are being reported. You know that these endothelial cells traverse multiple organs, lung, heart, kidney, intestines, and the vasculature, and pre-existing endothelial dysfunction is associated with smoking, hypertension, diabetes, obesity, and cardiovascular disease, and is more common in males than females. These are all the conditions that are clearly associated with more adverse outcomes in COVID-19, again on the same theme. As a matter of fact, a recent report that really just came out over the last couple of days, first initially coming from the Pediatric Intensive Care Society in the UK, and now as of yesterday from a United States Health Alert, and that they're seeing a number of patients, 15 cases in New York City hospitals alone, with a multi-system inflammatory syndrome very similar to Kawasaki's disease or toxic shock syndrome. Again, pointing towards that whole body inflammation that may be, again, all go back to the endothelium according to our current theories. Now, I mentioned we are going to cover some of the imaging manifestations. Plain radiography tends to come into use most often as a first-line test, and our imaging societies are reminding us that it's better to do these on portable machines than it is to do them on, built-in machines where the room care may be a bit overwhelming. It is important to know that chest radiographs may be normal in early or mild disease, so it's really not an effective screen, as a matter of fact. On the other hand, about 70% had an abnormal chest radiograph at the time of admission. About 80% of people had some abnormality during their hospitalization, and the findings tend to be most extensive about 10 to 12 days after symptom onset. The most frequent findings, as described on X-ray, are airspace opacities, which might be called a consolidation in some reports, or on the more suspicious reports as ground glass opacities. But to me, ground glass opacity seems better on a CT scan. Key hallmarks of the disease can be appreciated even on chest X-ray, with the distribution being bilateral, peripheral, and lower zone predominant. And particularly on chest X-ray, we tend not to see pleural effusions, rare in only 3% of cases. Here you see a relatively mild case. I don't believe you can see my mouse on the screen, but if you look at the chest X-ray, the PA view, you'll notice that there are these very poorly defined patchy opacities in the peripheral zones of the lungs on both sides, or the lung fields on both sides. Here are more severe cases. Clearly you can see the findings of bilateral. They're peripheral. You're starting to see some of the septal lines within the lung, just a more severe manifestation of COVID-19 lung on chest X-rays. Now, when it comes to CT imaging, clearly this is the more sensitive modality. The preliminary findings have been reported in multiple places: bilateral, subpleural, and peripheral ground glass opacities. You see intra and intralobular septal thickening with the ground glass opacities described as a crazy paving appearance. You may see frank airspace consolidation, bronchovascular thickening in the lesion, and traction bronchiectasis. Here you see some classic cases pulled from Radiopedia. I really salute the folks at Radiopedia for all the work that they're doing, keeping things contemporaneous, supplying us with classic examples. You can clearly see from these three different examples a bilateral distribution, a predilection for the peripheral lung, and even clearly a predilection for the lower lung zones. Perhaps the best paper currently available was just published in Academic Radiology, which looked at high-res lung CT and the manifestations of COVID lung in these patients. And you can see the same type of distribution, most commonly ground glass opacities. The ones with thickening, septal thickening, ground glass opacity with crazy paving, frank consolidations, stripe, which is a healing effect coming out of these other manifestations, as well as air bronchograms. Notice, by the way, cavitation isn't seen. Pleural effusions are hard to come by, so those should be seen as atypical. Here are some examples from the particular trial, from this particular paper. You'll notice the multiple rounded ground glass opacities on the upper set of images. As you move down below, you start to notice some of the crazy paving with thickening of the intralobular lines. Here you see another classic example: multiple rounded, peripherally distributed ground glass opacities, perhaps with frank consolidations. Now again, these ground glass opacities, the consolidative opacities, are bilateral, peripheral, and basal. Interestingly enough, 54% of asymptomatic patients that are COVID positive had changes that you can see on CT. And that may suggest that we should be doing CT as a screening tool, but there really isn't enough evidence to suggest that it is appropriate. Certainly the case can be negative on admission, and the literature isn't sufficiently supportive, so it isn't currently being used. Now, as you might expect, the Fleischer Society has stepped up, and this time in conjunction with the American College of Chest Physicians, and written up some fairly extensive guidelines, which I won't have the time to go through here today. But I would say that they do stress that imaging is not usually indicated in patients with suspected COVID-19 and only mild clinical features, unless they are seen as high risk for disease progression. In general, if patients are doing worse, that's when imaging comes into play. Particularly if you're in a resource-threatened environment where imaging can be the only way to make the diagnosis, imaging can be used in the more severe cases. There are folks already setting up structures for standardized reporting, which may help in research, clothing and data mining, and I won't go through these as well, but you can see that the findings can be either categorized as having the typical appearance that I've described, an indeterminate appearance, where you don't see the same type of appearance of the lesions themselves or the same type of distribution. Example might be a few small ground glass opacities which aren't round and certainly aren't peripheral. And then there are some things that should be seen as atypical for COVID-19, as I mentioned, cavitation, small nodules, segmental consolidations without ground glass opacities, and of course, under COVID, standardized reporting will always have a place for normal. Along with standardized reporting, we already have a proposed CORADS designation where CORAD 6 is a circumstance where you're already positive by lab testing, and then depending on how suspicious and how classic the findings are, we run from CORADS 1 through CORADS 5, CORADS 5 being typical and a very high level of suspicion. Now, you've already heard that complications from COVID-19 can be seen throughout the body, ranging from acute respiratory failure that we've talked about and pneumonia through frank ARDS, but you also see things like liver injury, renal injury, cardiac injury, any place there's endothelium. Here you can see a ring-enhancing lesion on this delayed post-contrast cardiac study. You'll hear a little bit about the tendency towards thrombosis and DIC and even rhabdomyolysis. Being a neuroradiologist, and also because it tends to be the newest area where folks are concerned, I'd like to spend a few minutes talking about the neurologic manifestations. And this paper came from the initial outbreak in Wuhan, China, and they saw a number of central nervous system manifestations, including headache that I've mentioned, but also dizziness, impaired consciousness, stroke, ataxia, and seizure. I mentioned earlier that the CDC has highlighted the classic and prototypical peripheral nervous system involvement by direct viral invasion of the olfactory fibers and gustatory process with taste impairment and smell impairment, but there's also been nerve pain and vision impairment, and there's also been recorded skeletal injury. A recent correspondence to the New England Journal just last week looked at neurologic signs and symptoms. There were certainly things like agitation, corticospinal tract signs. Imaging, I'll show you some examples of leptomeningeal enhancement, altered brain perfusion, and even stroke. And you'll notice, though, there was a reasonable amount of abnormality on CSF assessment, but no evidence of intraviral particles in the CSF. Here you see several examples from that particular paper. Hoping the white arrows will point out to you. Image on the far top left is pre-contrast, middle post-contrast T1, right post-contrast flare. You'll notice that there is hyperintensity or perhaps enhancement within the subarachnoid space, lining the sulci. You can see this also in the axial plane, lower left post-contrast T2 flare, and you see a focal parenchymal abnormality in the right frontal lobe on the lower one. This is perfusion. On the top row, this is arterial spin labeling, blood flow. On the bottom row, it is dynamic susceptibility contrast, blood flow. As is usually the case, the findings are much easier to see on the ASL, and you'll notice the arrows are pointing at the frontal lobes, and particularly the anterior medial temporal lobes pointing out abnormal perfusion. And this last example that you see here, you'll notice this is upper left towards upper right, pre-contrast T1, post-contrast T1, pre-contrast flare, post-contrast flare, and on both of them, notice the white arrow. On the post-contrast image, you either have a vascular structure lighting up or a focus of nodular enhancement. And if you look at the bottom row, the trace image on the left and the ADC on the right, you see there is a small area of acute infarction. So these are the typical manifestations that we're seeing. There have been some reports of acute necrotizing encephalopathy. This is typically a rare complication of influenza and other viral infections. This is predominantly described in the pediatric population, but can occur in adults as well. This is felt to be a result of the cytokine storm syndrome, which occurs when immune cells overproduce to combat an infection, which can potentially damage the end organ or damage the body, leading to even death. Again, it's an overproduction of immune cells, which breaks down the blood-brain barrier, but death. Again, it's an overproduction of immune cells, which breaks down the blood-brain barrier, but doesn't directly invade the brain itself. The most characteristic imaging features include symmetric, multifocal lesions with invariable thalamic involvement, but other areas can include the brainstem, cerebral white matter, and cerebellum. They appear low density on CT and hyperintense on FLAIR, and show both internal hemorrhage and areas of ring enhancement. Here you see one case that was supplied with that report, is the CT. The arrows show symmetrical bilateral thalamic hypodensity. Notice that the internal cerebral veins, the thalamic veins are open, and patent, excuse me, and the arterial vasculature is also patent and open. So this is not infarct related in this particular case. Here you see an MRI showing the really fluffy, juicy bilateral thalamic involvement, but notice the arrows are also pointing towards anterior medial temporal lobe involvement. If we look at the lower row, it is susceptibility weighted imaging and post-contrast T1, susceptibility weighted imaging and post-contrast T1, going left to right. And if you look at the susceptibility images, particularly image G, third from the left, you'll see there are clearly multifocal areas of susceptibility indicative of hemorrhage involving the thalami and anterior medial temporal lobes. And if you look at the post-contrast images, most markedly lower right, you'll see that there are some areas of ring enhancement within the thalami. So fairly classic findings of acute necrotic encephalopathy. Overall, I think the alarm is being sounded now because of the evidence of thrombotic complications associated with COVID-19, which again may all, harken back to the endothelial inflammation. In this particular report, they found a 31% incidence of thrombotic complications, which might be pulmonary embolism, DVT, and even stroke in ICU patients with COVID-19. A recent correspondence out of Mount Sinai reported a doubling in their stroke volume and involvement of a younger population. Again, correspondence out of Mount Sinai reported a doubling in their stroke volume and involvement of a younger population. Again, all pointing towards a thrombotic association with this disease. Now, one last piece on diagnosis. There are folks working on artificial intelligence to affect the diagnosis, as well as the longitudinal and quantitative assessment. Just a couple of words on this particular tool. Here's a recent report just published in Press just last week, looking at the performance of a machine learning tool against some radiologists. All of these comparisons, virtually all of them are skewed and hard to read analytically, but I'll just show you this case, which this set of examples, which is illuminating at the very least. This top row was nailed as COVID-19 and ultimately proven by the AI, but the radiologists were less impressed, I guess because of somewhat less typical findings, at least to the radiologist eye. The bottom row, both the radiologist and the AI performed reasonably well at making that diagnosis. As we follow, there are other tools, and this talk is sponsored by Philips. So I mentioned some of the Philips advanced visualization capabilities, but there are also some other entities that are taking tools that are existing. Here you see Philips looking at their current lung tools and expanding them beyond to perhaps adapt more to things like COVID that we're studying today, as well as companies like Cure AI that had a tuberculosis tool that is using it now, I believe off-label, but very effectively in looking at making the diagnosis of COVID-19 in pandemic regions. There is also a role for quantification in surveillance and grading in surveillance, and tools like IcoLung for micrometrics are starting to help with this as well. So at this particular point, since Kieran's off having a cigar right now, I think I'll go ahead and read this next question. And as a segue into where we're going to talk about workflow and efficiency, let's talk about what the biggest deterrent to workflow and efficiency in your CT suite. The questions are on the screen. Is it renal function screening? Is it getting IV access? Is it picking the actual protocol you need for the CT exam? Is it being stymied by pre-authorization that isn't obtained up front, excuse me? Is it patient safety concerns? Or is it staff safety concerns? Really important now in the COVID pandemic setting. You can go ahead and submit your answers. Hopefully you all have done that already, and we'll reveal the responses a bit later on in the program. Here is a set of questions for MR. What is the biggest deterrent for workflow and efficiency in the MR suite? Is it renal function screening? Is it IV access? Is it picking the appropriate protocol for the patient's history? Is it patient safety? Things like implants, conditional implants that you don't have enough information about? Or is it, again, staff safety concerns in this era? Again, enter your answers and we'll come back with this in a bit. All right, so when it comes to dealing with being an imaging provider in the post-COVID or after, once COVID, the pandemic is here, it's important to think about how we're going to answer the needs that will come up. And from our perspective, you may not know Radnet. Radnet is a leading provider of freestanding fixed-site diagnostic imaging services in the U.S. It's the largest. Last time I checked, we had 344 centers, did over 7 million exams a year, and a lot of people, working for us. If you look at a recent survey done by a company called IMV, you can see what has hit both companies like us, which are nationwide, as well as small and large providers, both in private practice as well as in hospital and academic practice. You'll notice from this particular chart that nationwide, the CT volume is down about 38%, despite the fact that CT can be very useful in the diagnosis and surveillance of patients with COVID lung involvement. But you'll also notice that MR is down almost 50%. And then the question is, well, okay, we've gone through this. At some point, elective procedures are going to start again, and they are starting in different states around the country. In general, when the elective procedures, elective surgeries start, the imaging tends to follow. So this group, again, asked their surveillance, so to speak, their survey respondents, what is the anticipated time that they think it will take to get back to the previous volume level, if at all? And you'll notice that some people predict a fairly significant rise very quickly, but for the most part, most people feel that it will take about 2 to 3 months, with some people skeptical say it's going to take 6 months or longer. There are some unique challenges in imaging in the post-pandemic era. The ones that are COVID related, which involve longer time to turn over a scanner and all of the procedures that you need to do to make sure the room is safe for the next patient, as well as for the staff operating and moving in and out of the room. This can create scheduling issues, particularly if you're one of those organizations that has chosen to keep certain facilities pristine from any concern over COVID and pushing patients into other who are suspicious into different systems. I think that may happen in hospitals more than it will in outpatient centers. The whole issue on no-shows and late cancels becomes even more problematic when you're trying to deal with a fluctuating environment and all of these other safety concerns, which really, again, emphasizes how important it is to get the exam done right the first time, because bringing someone back is going to be much more of an ordeal than it ever has been in the past in a non-pandemic setting. There will be staffing issues, as is widely known. Many radiologists have had to deal with salary reductions. There have been furloughs and layoffs throughout the industry. We certainly are not in an ideal situation to deal with surges in volume, and this will have to be carefully considered, and hopefully organizations will be proactive. I know that we are starting to ramp up as we come out of this crisis. There will be unique training requirements about scanner hygiene and the like And of course, there will be the unique issues here about in the staff about anxiety, stress, and morale that are not in routine everyday considerations outside of a pandemic. It is important to know that there are some unique pieces of technology out there that may actually come into play in circumstances such as this. And actually, the Philips CT scanner actually has a module that works from the operator's room that will allow you to do virtually all of the manipulations you need to do on a CT scanner table without entering the room. And certainly, this might eliminate the need to go in the room, but certainly would eliminate the need to go in and out of the room multiple times and potentially having to take off equipment going in and out of the room to keep the rest of the room sterile. So this is kind of a really nice feature for the CT scanning environment. On the MR side, we actually are already deeply involved with using remote operations of our scanners. We use this to distribute expertise. Our cardiac imagers at one site helping at other sites. Rookie technologists doing a problematic prostate MR, they get supported by a central site. But we also centralize training by bringing people in, let them watch multiple exams in the same day from the central site. But we also can use this to support staffing at the scanner that may be leaner because of health concerns or safety concerns or erratic staffing that comes up in the pandemic era. This is a technology we have running probably right now at maybe 10 to 15 sites and should get to 50 or 60 over the next few weeks, because I think it'll be particularly important to respond to the volatility that at least I expect. So coming out of the post-COVID surge, it has been noted by several that the amount of cancer surveillance imaging that is being deferred is formidable. This has to come back sometime. I mentioned as surgical procedures start again, demand will ramp up, and with furloughs and layoffs and changes in a location and social isolation, staffing is going to be a challenge for both recovery and dealing with fluctuations. And like many circumstances in day-to-day imaging, it does put a premium on our efficiency, our agility, and our resiliency and adaptability as we try and deal with these circumstances. And even things like this illustration on the right of standardized scan cards that will go ahead and pop the ideal protocol in for a typical circumstance, such as an agreed protocol in COVID surveillance, can be helpful and more efficient. So, for the rest of the half an hour that we have between us, I would like to spend some time talking about some of the efficiency tools that come into play on both the CT and the MRs that we have installed in our institution. One of the biggest, most powerful tools are tools that are dedicated to automatic scanning and enhanced workflow. Whether it is automatic detection of cardiac rhythm and respiratory rate, so we don't have to put on bellows, or things like staying at the scanner and being able to control virtually every individual piece from the scanner console, so I don't have to go in and out of the room a lot, or even operating, again, totally within the room. These tools that work on the CT console have actually been shown to reduce the time to exam completion and results by about 19%. And that's pretty impressive as far as I'm concerned. This is one of my favorite slides, which really does illustrate the value of automatic scanning. You may notice this screen. There's about 500 or so folks here with us today. Some of you guys are technologists. You may recognize, the dreaded 5 localizers in a row, and this is because sometimes it's really hard to find the anatomy. When you look at our data, you'll notice when you look at our localizers, most of the time in an exam, we'll spend about a minute cumulatively on localizers, but sometimes we're way out here in the hinterlands where we don't want to be, and that's because sometimes localization is tough. And things like smart exams that do automated scanning coverage, automatic scanning angulation can have an enormous impact on our ability to do this kind of work more efficiently. We've actually looked in our institution at 2 scanners with the same protocols and same readers in the same neighborhood. One had automatic scanning tools and one didn't. And we had a statistically significant difference in the table time for the patients when we had automatic scanning going. And as you might imagine, that's not too hard. It's not too hard to get an understanding of how that would happen. There are other things that just improve workflow as an automatic vertebral body labeling. It definitely helps the reading physician when you do scanning with an automatic engine because the positioning tends to be more consistent from exam to exam. Here you see different visits in the same patient, excuse me, and very consistent positioning from visit to visit. Here you can see how it can be very difficult to do surveillance in a treated brain without having virtually the same position each time. You'll notice if you look at the frontal horn of the right lateral ventricle, there are small linear and perhaps nodular areas of enhancement on exam 1. On exam 2, with virtually identical positioning, you can clearly see that the more lateral nodule has increased in size and the more medial nodule is the same or slightly smaller. Some things that are just impossible to do with human operators can be simple, like a triple oblique orbit to get the optic nerve in one shot can be very helpful. And this type of symmetrical positioning can be really critical in showing you that the left optic nerve, sorry, I can't point at it, is got a little bit of hyperintensity just before the chiasm on the left-hand side compared to the right. And that'd be very hard to see or describe if you didn't have perfect positioning. Now, the industry is also moving towards protocol optimization, bearing in mind that more is not better. Despite the fact that we all have the way we like to do things, the world is moving towards more concise protocols. And this is some nice work that the Philips folk did with the University of Utrecht, looking at common exams that they can get done in less than 8 minutes. Here you see a typical brain, normal one on the top, 8-minute total cumulative scan time on the bottom, little lower spatial resolution, but clearly makes the diagnosis. An efficient abdomen in less than 8 minutes. Again, looks like it makes the diagnosis. A 7-minute knee versus a 20-minute knee. You can certainly see the finding, even though the resolution is a little bit lower. How did the readers rate these studies? They rated them pretty well. No significant difference in diagnostic value. Slight difference in their appreciation and ratings of the exams, but pretty close and certainly all diagnostic. Now you'd say faster scan times are nice for efficiency, but they're also really nice for the patients. And the Philips folks did this study with 300 American and 300 German patients, and they asked them, how do you like being imaged in an American radiology department, in a radiology department, could be in Germany or in America. And you can see they like the process until they get to us. Then they don't like being prepared for the exam. They don't like the exam. They don't like the follow-up. It's pretty low rated. As a matter of fact, if you ask patients what they care about the most, right up there at the time is the lowest radiation dose and the shortest scan time. And that shows you the value, despite the fact that it's an efficiency boost of getting the scans just a little bit shorter. This is one of my favorite letters. Shortly after I joined Radnet, we had just gone through an optimized protocol by optimizing what we were going to do and how we did them. And this patient came in and said, thank you for putting me on that new machine with the 15-minute scan. I was in so much pain. It was great to get off the table so fast. As a matter of fact, when the lumbar spine was non-illuminating, she came back for a hip the next day and asked for the same machine. Interestingly enough, it wasn't a new machine. It wasn't a new set of it wasn't anything technology. It was about optimizing protocols and optimizing sequences that got her scan time down to 15 minutes. This is another one of my favorite comparisons, looking at a 1.5 and a 3T in the same building. You may know that 3Ts are less comfortable, they're hot, they're loud, but you may be surprised to see that the ratings we get, in this case it's a 4-point Likert scale, where the relationship between the gray, which is a rating of 4, and the blue, which is a rating of 3, will kind of reflect how happy the patients are. You'll notice that when we go to the 3T, we have a better ratio of 4 to 3. And when you go to the length of scan, you'll notice that 53% give us a rating of 3 or 4 versus only 42% giving us, a rating of 4 versus only 42% which give us a rating of 4 on the 1.5. So why would I get a better rating on length of scan and essentially the same rating on comfort, little ding on noise? Why would I get that? Well, the only reason to expect that is if the scans are consistently shorter on 3T. And as you can see from these bars, with this orange bar being the 30-minute table time, you'll notice that both the diagnostic portion of the exam on 3T as well as the overall table time on 3T is just a few minutes shorter, maybe 10 to 15% shorter, and patients rate that benefit fairly highly. You know, when you talk to patients, we think of MR being as really not too stressful, maybe patients with claustrophobia. have trouble, but most people don't. Well, it turns out that some people find the MR experience scary and painful, and some just find it long, tedious, and nerve-wracking. Patients associate the MR experience with feelings of fear, anxiety, reduced control, and abandonment, with anxiety reactions happening in up to 30% of patients. So again, a little bit of faster exam gives a much better patient experience. So what kind of tools do we have today that can make the scan experience go better, that go beyond the things we've talked about so far and more into, say, image reconstruction? Well, one of the most impactful tools is this innovation called compressed sensing. As you know, if you look at these diagrams, left-hand side of your slide, traditionally MR is read out line by line with a time penalty period with every line. If you undersample, you will actually get faster speeds, but then you generally have trade-offs in terms of artifact. Now, a very aggressive version of undersampling is compressed sensing, and if it's done in a non-balanced sense, what's called discontinuous sense, you can have limits on how hard you can push it, how fast can you go, and pushing too far will manifest in inferior image quality with loss of SNR and blurry edges. Whereas if you do this in a balanced fashion where the sampling is pseudo-randomly distributed nicely, you will actually get better acceleration capabilities and not give up any image sharpness. For compressed sensing to make a big difference to us, it needs to be adaptable to all acquisitions, and it is. Here you see a nice example where the typical brain MRA, which might be done in 4.5 minutes, is done with the same quality in 3 minutes. Here you see the typical venogram on the left in 5 minutes, done with compressed sensing factor of 6 in under 2 minutes. That can have an enormous impact. Something else you can do with compressed sensing is you can take the time you use today and raise your spatial resolution and raise your quality. Why would you want to raise your spatial resolution? For all the typical reasons, including if you were moving to 3D techniques and you want your reformatted images to look highly diagnostic and not look reformatted. And you can see from this particular approach with compressed sensing, we've ended up with images that I can't tell what's sagittal, which one is the acquisition plane, sagittal, coronal, or axial. In this case, it happens to be sagittal. Here you see another example, a sagittal 3D T1. And when you look at the reformatted images, you're hard-pressed to say which one is the acquisition plane, sagittal, I believe, in this case, and which one is the reformatted plane. Now, when you can use compressed sensing across the board, you can get some impressive benefits in terms of scan time as you when you institute these tools to your routine protocols. And here you can actually see Radnet data, where we had our old protocols where, say, a brain with and without had 17 minutes of cumulative scan time. We can take that thorough clinical practice every day with and without study down to less than 14 minutes, about a 21% gain. You can see, depending on the protocol, we can get close to a 50% gain, yet maintain the exact same image quality. This isn't a low-res study. This is a typical high-res clinical practice study done in about 8 minutes, including susceptibility-weighted 3D imaging in less than 2 on the protocol. You can say, again, say virtually any acquisition, 3D, 2D. Here you see a small vestibular schwannoma deep within the left internal auditory canal, as well as seeing some of the vascular structures and other cranial nerves very nicely on this cysternographic image. Here you see a typical MS brain with a 3D flare and a full resolution remainder of a study. You see this is done in 10 minutes and 42 seconds. And again, that can be very nice for these patients who come back on a regular basis. You'll notice from this particular set that we're getting benefits in the spine from our protocols to our protocols running from 30 to 50%, depending on what we're looking at. These are all done with compressed sensing, available for all contrasts. You can see from this slide, maybe you can't because it's too small, so I'll go ahead and take it up, that you can do things in a number of different ways. You can go fast. Each one of these series is a little over a minute. Add the axials, now you're talking about 6 minutes. Or you can say this one, little higher resolution, 1.5 minutes a piece, closer to 2 minutes. Or you can go take the speed and turn it all into resolution and bump your quality up and get it done in looks like 4.5, 6.5, maybe 10 minutes, 10, 11 minutes to this approach. And this can apply, again, you can see the typical exam on the top, typical exam on the bottom, same patient, scan both ways. you can see we can get the scan time down to 14 minutes for a with and without study, which, the kind of studies that would ordinarily blow up our schedule can now be done conveniently in a patient-centered way. Here's a typical 11.5-minute lumbar spine. Here's what it looks like going side to side. No compromises for slice thickness, no compromises for coverage, just better speed by maintaining image quality. The same approach here. You can go fast, less than a minute a plane in the sagittal plane, a couple minutes in the axial plane. You can pump it up to about a minute or two, or you can even go a little further again because you have the leeway that the compressed sensing gives you. Some of the exams that used to just kill us, like the sacrum, can now be done in a very concise 10 minutes. All 6 of these high-resolution sequences in 10 minutes. A brachial plexus, which can ordinarily blow you up. 7 sequences, including 3Ds, 6 sequences, including 3Ds, all done within a 20-minute exam slot, which is really very compelling. Well, this doesn't run anymore, interestingly enough. Which fundamentally means they didn't load the latest version of my talk over there at Applied Radiology. I'll have to have a word with them later, but you can see in this case, this lumbar plexus exam, again, done really nicely with compressed sensing. Now, same thing applies in musculoskeletal imaging. You're seeing about a 30 to 40% boost in speed with no change in resolution or slice thickness or quality. Typical knee exam you might get done in 8 to 10 minutes, which I think is really nice. Same thing here with the 6-sequence foot and ankle exam, again, seen pretty nicely. In the body, there are some circumstances when we can go faster, say in the pelvis, where we can devote some of that to higher resolution. In other cases, we're simply going to keep the routine amount of scan time. Now, again, I have a couple minutes left to go before we go into Q&A. There is one last set of considerations, and that is one of the things that blows up our workflow that gives us chills is when a patient shows up in the suite and we find out at the last screen that they have an implant in and we don't have the sufficient information, or we may not feel comfortable with the scanning protocols. As you know, there are about 3 million new implant procedures per year. By 2020, the number of patients with implants will have grown by 71%. Okay, so, this was put in, I think, one slide too late. So let's pause there for a second. I'll take a deep breath and we'll show you what the results were to your efficiency in workflow, and efficiency in the CT suite. You can see that CT function, renal function screening is high on the list. It's my fondest hope that the ACR will free us up from screening for CIN, which is a dubious concept at best. You can see that pre-authorization is not inconsequential. About 18% of folks said it was their biggest problem. But you can see now patient safety, which might pertain to the implant discussion I'm talking about on MR, but also staff safety is now one of the biggest concerns that we have, again, pointing to some of the efficiency tools that we needed to be concerned about. In the MR area, you see renal function screening isn't done as much. IV access doesn't seem to be as big of a problem. Protocol selection is not inconsequential. Patient safety with implants seems to come up even more than staff safety here, which is, at this point, a good triage into our discussions about implants, about safety with implants. All right, so when you look at our patient population that shows up on the MR scanner, there are about 12.5 million people in the US with implants, 10.3 million are 65 or older, and as you know, our MR and CT population tends to skew older. The likelihood of needing an MRI increases with age. As I said, 70% of people over 70 will have had an MRI. Now, you saw the picture of me at the beginning. That's what I looked like, before the pandemic. This is what my hair looks like now, and except on the one side where I'm tearing it out, trying to figure out what kind of an implant this patient has. Is it labeled? Is it conditional? What are the conditions we have to operate on? And how can I operate my scanner safely and carefully and without a significant impact to our workflow in our busy day? And this really ties into this ScanWise software. There are other versions on the market at this point. ScanWise was first to market and does a really nice job of this in terms of helping us cope with the defined thresholds that these devices come with in terms of how we operate them and where they can be positioned in the MR scan bore. Traditionally, without tools like this, we have an indirect manual setting of parameters with each individual sequence. This can be both time-consuming and error-prone and operator-dependent, and will have a significant impact on workflow. It is much better to have sort of inline software that will take us through the process step by step, reassuring us that all of the considerations come into play, and stepping each step along the way until we have the final recommendation and the final entries on our forms as to all the individual pieces that we have to enter in, like the spatial gradient, the SAR localization, even putting in notes from the chief tech telling the staff at the scanner how they're going to go about this particular case. As a matter of fact, even with this guided scanning user interface, it even shows the areas where the implant should not be close to during the actual scanning in both the front view and side view and top view as we go through. It should help us. So we've covered a lot of things. We did a little bit on what COVID-19 is. We talked a little bit about the contemporaneous imaging issues we're going through today. And then we started to talk about technology and tools that may help us deal with and emerge from the post-pandemic era, including opportunities that really do make a difference, like automated scanning, reconstruction tools like compressed sensing, and workflow enhancing tools. So I hope that was fun. We do have a little bit of time left for a Q&A. And I would like to, at this point, thank you very much for your attention.
Well, Dr. Tanenbaum, thank you very much for the time you put into that talk and for joining us today. I apologize for one of your videos not playing properly. I'll take full responsibility. We have a lot of questions that have come in already. We've got about 9 minutes until the top of the hour, so we'll try to get to as many as possible before we get to the top of the hour. With that said, let me remind anybody in the audience, if you do have any questions, please feel free to continue to submit them. So let's get right into it. Here's a question that comes from somebody about MRI op appointments and based on the examination. At Radnet, are they all fixed time lengths, or do you have some sort of a modified approach?
Well, thanks for the question. At Radnet, we have a trend towards uniform exam slotting, with our exam slots being 20 to 30 minutes, depending on the region and the level of the technology that we're actually operating on. In other parts of the country, we might be 20 minutes and 40 minutes. But in general, the entire standardization, our agility and ability to adjust to fluctuations is always best with uniform exam slots. And in general, that requires you to pay particular attention to your outlier exams, your spines with and without, your prostate exams, your breast exams, with the appropriate attention. These fit right in all of our regions with the rest of the exams that we do.
Thanks there, Dr. Tanenbaum. You talked a fair bit about some of the CT findings for COVID-19 disease. In your opinion, are there any clinical indications for the use of MR as well?
You know, I think in terms of screening for the classic manifestations of the lung disease, I think CT's really well suited to this. It's fast and it's entirely diagnostic. It doesn't surprise anybody that we can see some of these abnormalities on MR, but it's not the first line, it's not a top line imaging modality until you start getting into some of the complications we described with patients with a variety of either clear or vague neurological symptoms. You've already seen circumstances where there are cardiac complications, even musculoskeletal. So MR is a wonderful modality for that, but I would imagine there's not a lot being done in this acute period, but there may be a fair amount of outpatient work or patients who are concerned about vague or even suggestive symptoms may come in for outpatient MR. I anticipate some, and I think there already is some going on.
You know, you mentioned a couple of times in your talk about volumes going up or going down. We saw how the audience felt about what might happen. There's a couple of questions related to this, and I thought maybe I'd ask you, what are you guys doing at Radnet to try to determine whether, where there may be increases in demand for your imaging services? Do you expect a surge or a slow ramp up yourself? What are your thoughts there?
Well, I think we're aware, as everyone else is, that as the outpatient procedures start to open up, the demand for imaging is happening. I have friends up in Northern Cal who tell me that this is exactly what's happening. They're starting to see a ramp up. We, in the outpatient setting, are starting to see a very slow ramp up in the East, a bit more robust in the West, but we also, being largely centered in New York, got hit pretty hard in New York City, not so badly in the West or in the other Eastern Seaboard locations that we have. We are seeing it. We'd all like it to be faster. I don't think it's any surprise. I would be surprised if it behaves nicely and then we have 10 cases on Monday and 12 on Tuesday and 14 on Wednesday. I think we're going to get these in fits and starts, like as it is when there is no backlog in demand, but it will certainly come, and it's already starting, albeit slowly.
Appreciate your thoughts there. Question here about, will there be a need, I'm thinking they're saying here, will there be a need to develop lung MR for helping with COVID diagnosis provided the CT findings? Okay, let me just read this again. Do you think that there's a need for developing some kind of a lung MR technique for those patients who are showing up with COVID on their CTs, or even before, maybe on a chest X-ray?
Has somebody converted my CT scanner to a mobile device and run in my building with it? That would be the main reason to do that, I think. I'm not really, CT, I'm not very concerned with diagnostic imaging radiation dose, and I'm certainly not concerned with the radiation dose of a modern chest CT, which can be very low dose and approximate a chest X-ray. So I don't really see any compelling reason not to use CT. Undoubtedly, with the appropriate protocols, we can see things in the chest with MR reasonably well. And we may find ourselves imaging the heart for patients with unexplained cardiac symptomatology, as well as other organs. But, I don't think I'm going to be too wrong if I say there's not going to be a ton of interest in pulmonary MR. But if there is, I won't get invited back for part 2 of this webinar.
Over in the UK, somebody notes here that they've placed all their referrals on hold. That seems to be the case across the globe. Do you think these referrals need to be returned to the clinician to be reassessed, or should they still be honored?
Well, I think you're not operating in a vacuum, right? If you have an order and the patient presents, I would say that as we start to come out of the restrictions and we get the green light to image, I would say those will all suffice. At Radnet, we tended to let the referring clinicians determine the urgency of these exams. So we have been open. We maintain many facilities that are open and standing ready to perform imaging in all of our territories. There's no lack of capacity, but we have let the referring physicians drive is something being urgent or not, or worthy of imaging. I would not be concerned about taking the existing orders as society opens, as these facilities open, as procedures open, to just take them as the patients come in. I'm not concerned about that, but right now during this admonition period, this restricted period, when a physician calls for an exam, fully aware of the restrictions, we are doing them. The one big exception would be the pure screening procedures like mammography that have been specifically addressed by the regulatory agencies.
Couple more quick questions here before we wrap things up. Dr. Tanenbaum, going back to AI, you mentioned that in your talk. The question is, artificial intelligence now has a high opportunity to evolve in order to assist workflow and increase diagnostic speed and accuracy. In a post-COVID world, what is your opinion in this matter? I'm sure you agree, but do you have anything else to add to that?
Well, gee, do I have anything to add about AI and the imaging enterprise? Gee, where can we start? I'm a big believer in where AI is. I think, frankly, even compressed sensing done well is a machine learning application. Automatic scanning is a machine learning application. And we are already seeing FDA-approved machine learning convolutional neural network-based image reconstruction tools that just piggyback on top of the advances you heard about with compressed sensing. They're essentially let you do today's work faster, maybe 40% faster, maybe 50% faster. And again, they all piggyback together, all of which will point to an exam in MR that at some point, you may even be able to just walk in, grab an MR and go without even making an appointment, as long as you have the appropriate doctor's orders. So yes, AI is already accelerating processes. It will have the same benefits on patient acceptance. It will have the same benefits on workflow and throughput. And I'm very optimistic and very bullish on the capability.
All right. Final question for the day. Do you consider scan room air volume turnaround time between all patients?
Yeah, I actually not the best expert to comment on that. We are following recommended procedures for cleaning the rooms. I don't know that we have, that much volume to be terribly concerned with how many hours we are between patients, but I'm not really comfortable speaking about how long we go between patients because I'm not entirely sure. Sorry about that. I would say that as an organization, Radnet tends to be very fastidious about following regulatory recommendations and policies and ACR recommendations and policies. So, but offhand, I cannot speak to those.
Okay, one more final question. What are your suggestions for managing asymptomatic patients who may come in with other clinical or non-COVID presentations when after the initial imaging is complete for the emergent issue? Do we find out that they really were COVID positive, i.e. deep vein thrombosis,
I think in this,
et cetera?
In this area, everybody is wearing a mask to protect others from them, right? And that reduces your chance of transmission substantially, right? So our staff is protected. Our machines and rooms are made sterile, and all of our patients are following the isolation recommendations and wearing a mask themselves. We do the best we can under those circumstances, and we maintain the hygiene of the room between patients. And that's really, to my perspective, which may not be the formal corporate perspective, to my perspective, we're doing as well as we can. And I think patients should feel comfortable coming into getting images under those circumstances.
I think that's a fair statement, Dr. Tanenbaum. And with that, I think we'll wrap things up here. We've reached the top of the hour. I personally would like to thank you again for taking the time to join us today. I appreciate it, and I'm sure the folks in the audience did as well. So thanks again, Dr. Tanenbaum.
Thank you, and thanks to everybody who took the time. I hope it was worth it for you.
So with that, let me again thank Philips for making today's event possible through their sponsorship of this webinar. As always, we also want to thank those of you in our audience for joining us today and your continued support of Applied Radiology. We hope that you did find the event useful as you prepare and continue to prepare your departments for what we hope in some sense is back to some sense of normalcy following this pandemic. But equally importantly, we hope that you and your families remain safe and healthy during this unprecedented time. With that said, we look forward to seeing you online again in the future. The webinar has now ended.